So welcome again to episode 4 of Dental Raves and Rants podcast. And today's topic is post or no post, question mark. This is a very interesting topic that I get asked about all the time in the student clinics. So we'll do a quick literature review about some of the evidence that's available. So I would like to start with a very good statement from this paper in 2003. So dentistry has moved from extension for prevention to prevention of extension, and that I think sticks with a lot of us with the change in the paradigm and the paradigm shift that we see in dentistry. A terminology, and Dr. McLaren knows I like using small abbreviations, so that the one that I'll be using again and again today would be ETT. And when we talk about ETT, this is not the extraterritorial I'm talking about, but I'm going to talk about the endodontically treated teeth today. So that's the ETT I'm referring to in all my slides. Just to go to the definition of ferrule, because in order to decide if a post is needed or not, we really need to talk about ferrule, and we cannot get away from that. So the Webster Dictionary definition of ferrule is a ring or a cap, usually of metal, put around a slender shaft to strengthen or to prevent splitting. And this also comes from the plumbing industry, where actually the ferrule term generated and then was applied to dentistry. So what it means is a ferrule provides a sealed compressed fitting to prevent gas and water leaks on the plumbing system. And a plumbing ferrule is actually a type of cap widely used in pipe and fixture joints, as you can see in some of these images. And then it could be a double ferrule or a single ferrule, and front ferrule, back ferrule. So basically that's where it comes from the plumbing industry. And then how we apply that in dentistry is, so that's the dental definition from the Glossary of Prosthodontic Terms, GPT-9. It's defined as a band or a ring used to encompass the root or crown of a tooth. Or you can also define it as any short tube or bushing for making a tight joint. And then we all know the classic literature on ferrule effect, and we kind of learn and have hammered this ferrule term down as dental students all the time. So to understand how it impacts our restoration design, so ferrule design per Sorensen and Engelmann classic paper seems to increase the fracture resistance of endodontically treated teeth, or ETT. And then this is in this picture. I don't think you can see my cursor, but the arrows point it to the overlapping of the crown and dentin, and that's the ferrule effect that we talk about in terms of dental restorations. So this is actually a nice picture that shows the tooth restoration interface, the overlapping of crown and dentin. And as per the study, like I said, ferrule design increased the resistance of ETTs. So again, going into some more literature about this, studies have reported a minimum of 1.5 to 2 millimeter of ferrule that is needed to improve fatigue resistance. But, however, this has been investigated for cemented PFM crowns with posts. So you have to pay attention to how the evidence came into being, and then the question comes up, does it still apply to the adhesive restorations that we do more and more in our practices today? So the RCTs that were done, they all showed better survival rates of ETTs with PFM crowns restored with post than without post. Again, the evidence was for PFM crowns with post. So is it still relevant for bonded edge ceramic restorations? So let's look at the evidence about that. Now, can we lose ferrule? Of course, we can lose ferrule by aggressive crown preps, by over-preparation of teeth to achieve retention or resistance form, and heavy shoulder margins, and as we popularly call them, as serial pulp killers. Who do these kind of heavy shoulder preparations. And then some of the no-post approaches and alternative strategies we all know are surgical crown lengthening and orthodontic extrusion. But the problem is they are all time-consuming and do not produce results in a single restorative appointment. So what is the new postless restorative approach, which is the endocrown? That means using the pulp chamber as an extension of the crown itself. So the first published article, believe it or not, was in 1995. This is not new. It was originally called the monoblock technique. And then this is a very, again, old classic paper about how they utilized the inside of the pulp chamber to produce a monoblock restoration. And it was done for both anterior and posterior teeth, which was a single element ceramic restoration. So then we talk about what is internal ferrule or adhesive ferrule. So the internal walls of the pulp chamber can be used to bond the core buildup. And then this is without any intracanal retention. And Mania's group has done a lot of in vitro studies for the restoration of endodontically treated molars with or without ferrule, with adhesive core buildups, and we'll look into that evidence in the next few slides. So again, paper by Cavallo and Manier, accelerated fatigue resistance of endodontically treated incisors without ferrule, restored with CAD-CAM endocrowns. And in this paper, they talk about, they say the endocrowns do not fully compensate for the absence of ferrule. The ferrule effect outperforms all non-ferrule approaches, and the endocrowns perform superior to fiber post with composite buildups. And the post and core approach failed to increase fatigue resistance, and the post and core approach resulted in catastrophic root fractures. So this was the outcome of this study. So brings us to the same question, post or no post? And the other question I asked all my students is, what is the original purpose of the post? So the original purpose of a post is to retain the core and not to increase the intrinsic resistance of the root. So that's the myth that we all have, that somehow post is going to increase the fatigue resistance of the tooth, but in fact, it causes more vertical root fractures and terminal failure of the ETTs. And then, like I was saying earlier, the evidence, went too fast. So the evidence that talks about post-endodontic restorations and endodontic post and core or no post at all, they say there is no unequivocal clinical evidence to support or reject the use of posts, even for no wall cavities, either for direct or for indirect restorations. A positive effect of post placement was shown by 4 out of 11 randomized controlled trials when no cavity wall was present. And then 3 additional clinical studies demonstrated no post effect. So the clinical evidence is actually lacking on the influence of tooth location in the dental arch on the survival of post-retained and post-free post-endodontic restorations. So that's what this review said. And then what comes first? Ferrule comes first, post is second. Is this true? So this is a very nice paper that talks about how to kind of analyze whether my ferrule is important or my post and core is important. So ferrule has a supportive effect on restorations, and most studies fail to show the post effect. So between ferrule and a post, ferrule always wins. And then this was another paper and a study done for CEREC endocrowns. Endocrowns were done in a single appointment using chairside CAD-CAM. And then the short-term survival rate of the CEREC endocrowns was actually 90 to 95%. Then, again, a series of papers, in vitro studies done by Manier and Carvalho group. They study about the influence of no ferrule, no post build-up design on the fatigue resistance of ETTs, and then restore them with the nanoceramic CAD-CAM crowns. And then they also investigate the adhesive core build-up designs on the resistance of ETTs with lithium disilicate CAD-CAM crowns. So very interesting 2 papers. And then this is a very good diagram that they show where they talk about the advantages of the adhesive core buildup. So then what they found in this study was 2 millimeter core buildup was more favorable. There was no added benefit of the 4 millimeter core buildup, and Dr. McLaren talks about that in his lectures as well. I know because I have heard him lecture for quite a while now, that you do not have to create that 4 millimeter of core to get that retention in an adhesive type of ceramic restoration. And we'll talk about that later in the talk today. And the limitation is the self-adhesive cement that showed no benefits for endocrown with no buildup, which was also part of the test study that this paper talks about. So then let's kind of do a take-home message. The ETT, endodontically treated teeth with ferrule, the question is, will the glass fiber post benefit when a tooth has ferrule? So I would like to answer that with another paper from Manier, which talks about ferrule effect dominates over use of fiber post when restoring ETTs, and they showed that through this in vitro study. So what they saw was there was catastrophic failure was seen every time there was a glass fiber post. And then the fiber reinforced post does not enhance the survival of all ceramic crowns. So there was no added benefit that was seen. Now, let's talk about the other scenario where ETTs with no ferrule. Do ETTs with no ferrule need a post then? Because if ferrule is present, then the post did not categorically give any added benefit. So do we need a post if the ferrule is lost? So again, another paper in JPD that talks about fatigue and failure analysis of ETTs without a ferrule. And then in this paper, this is how they check the failure modes of the dowel group, without dowel group, and the incisor. view. So the conclusion was the use of a glass fiber dowel did not enhance the survival of ETTs restored with bonded lithium disilicate crowns over composite resin foundation restorations. Again, the limitation is this was an in vitro study, but you see the results clearly that less catastrophic failures were found in composite resin foundation restorations without dowels, no ferrule, while the use of dowels was associated with 100% catastrophic root fractures. And the picture speaks for itself. Then the last paper I'm going to talk about today is the clinical evidence on endocrowns, another good study that showed estimated survival rates of 98% at 10 years. And this was a retrospective study of documented endocrown cases. And then this is how they had the design of the restoration. So I cannot use my cursor for some reason, but you can see the picture speaks for itself. And the last slide for today is, so the advances in adhesive dentistry and the paradigm shift that we have been seeing over the last a decade or so, post-this approaches and restoring ETTs with ferrule are becoming common every day. And the present data support the use of IDS procedures, and we can talk about IDS in our future talks as well, and the evidence around it. And this could also contribute to the high success rate in terms of debonding. So that concludes my presentation.
I think for a second we need to add a little bit more definition to the ferrule, and maybe you did because you threw a lot of information out there. As defined, the ferrule is essentially a band that supports externally some structure. Okay. In the old days, in that zoom right there that you have, where your mouse is going right there, the post is acting as a ferrule too. So the authors or the diagram bevels the edge of the dentin to get a ferrule effect on the cross-hatched post that you have right there. Yes. But and I'm not sure you explained this, the crown actually acts as a ferrule too, or the restoration acts as a ferrule if it's prepped beyond the edge of where the fractured tooth is. Did you discuss that or cover that?
I did not.
Okay. No. So what my contention would be, and I've heard other speakers do this, and I don't know that this is fundamentally been tested, but logically it makes sense, that if you're going to prep like that slide shows, okay, that you don't need to bevel the tooth with the metal post or the ceramic post or the composite post. That tooth structure could theoretically be saved. And it's, if you saw Martinoff and Sorensen's study from a few years ago when they went and looked at, went into dental offices, looked at success and failure, looked in the charts. They didn't actually see the patients, but the teeth that appeared to have more remaining dentin was one of the keys for success, long-term success of an endodontic treated tooth. So my thought process is I wouldn't be beveling the external of the dentin. I would be looking at the restoration as a part of that would create some ferrule effect or some grab. Let's think that's a micromechanical retention that helps resist in lateral stresses. So you other two gentlemen out there, why don't you jump in and give a little thought on so far what you've heard?
Well, I'll jump in because I'm in Southern California and I've been following. I haven't placed a post. We'd have to go back into the early 90s because Bogan and Charlie Cox and all these guys were some of the early influencers of us on this whole philosophy. So what I can say in clinical practice, it works. And the key being and I think now Pascal's talking about, we would always kind of shoot for 3 millimeter ferrule. Mm-hmm. And if you have a 3 millimeter ferrule, you're pretty golden. And so the argument would become use the post to support material.
Yeah.
Well, if you really want to do that, then just take some carbon fiber, some ribbon or whatever. Mm-hmm. But even that, you kind of then wonder, well, is that contraindicated too? Because when that carbon fiber becomes loaded with resin, it becomes stiff. So that does it now act as a fracture potential. So for me personally, since it's before 2000, it's in the later 90s, I have not placed a post. I think the last post I had was snow posts from Danville.
Yeah.
And have not posted. I haven't put one in and have seen things last a long time. So this kind of discussion for me is it's just like...
I'm on a similar thought process as you, and Dr. Ortiz will let you jump in a second. being involved with Sorensen over the years, he was jokingly referred to as the first prosthobontist by Ray Bertolotti, because he was one of the early adopters of adhesion as a prosthodontist. Okay, and he did some studies with M-Press, clinical study, endocrowns, that I was part of when at UCLA, but it was really his study. And he followed close to 40 restorations where he just did a 2 millimeter internal engaging the canal with M-Press, the original lower strength material, and then just restored the top of the tooth, and then a little bit of ferrule, or wrap around the outside. And God, I think at 5 years there was 0 failures. So
I remember when Bertolotti presented that piece of research. I mean,
So clearly, we overuse post. One slide maybe we should go to that would help, I think, all of us with this discussion. Anvita, when you were talking about Dr. Magnier's research, Pascal's research, you showed let's scroll down. There was a slide where you showed something like that. There was actually some fracture even. Yeah.
Wait, hold on. This one?
There. Okay.
Yeah.
We're back one. Okay. The one you just clicked just before that, even one right before that. Okay. That you just clicked on. Okay. Yes. Oh, yeah. There. Okay. So so Dow Group D, where you actually engaged the canal on top of that internal projection down into the canal space, not the root space. That my understanding is that from this data that had a much higher fracture potential than the one 100%. In the middle. Yeah, that has no post in there. Okay, and I can tell you that's been my experience over the years. And I think part of the reason is that what happens is when you place that post on the left, you end up just damaging too much tooth structure. I'm not so sure it's so much stress to the root, because you were showing that the post actually fractured. Okay, I have not seen clinically, and love Dr. Ortiz, you to chime in here, don't mean to dominate. I have not seen clinically a tooth fail that had a fiber tooth post in it. I mean, where the root fractures. Certainly over the years, I think all of us have seen, like that image on the right, where it's been a metal post, or somebody opened up the canal space so large that there was so little tooth structure left. Dr. Ortiz, your thoughts on this, please.
My thoughts are a little bit different than most people. Coming all the way from residency, I haven't placed a post in 10 years either. There's something called, I was looking it up on my phone because I didn't remember exactly how it was, but there's something called survivorship bias. Have you guys heard about survivorship bias?
I've heard the term, but define it for us.
So survivorship bias was something that happened supposedly in World War II when they were trying to figure out how to make the planes, the bombers, and the fighters survive more. So every plane that came back to base, they would analyze all the damage that it had from the opposite side that were shooting at them. And they had all these holes all over the place, and some places have more holes than others. And so the engineers were thinking, well, maybe if we reinforce this part of the plane, they will survive more. And there was a mathematician who could say, no. We have a problem here. These are the planes that came back that have these holes. And if we make decisions on the planes that came back, we're missing all the places that didn't come back. And maybe the places that are not holed out, the places that don't have hole in the place that came back, are the ones that got hit there and are the ones that went down. So we might have to reinforce the areas that are not damaged in the planes that came back. And that came back to be true. The ones who were shot in the engines did not make it back. The ones that were shot in the wheel came back. So you want to reinforce the wheel because you see holes and you don't see holes in the engine. To me, this entire thing about posts can be explained by two things that are related to survivorship bias. One is that in the past, we did not have adhesion. That is clear. So we need a retention or resistance. And we saw failures. We saw fractures if we didn't have failures. However, if we are to go back in time, we're going to probably find the same thing that we find today. If you treat 7 to 8 patients a day, like a regular dentist will, for 4 or 5 days a week, you will definitely see less teeth fractures than those with caries. So caries are much more prominent than fractures. I'm talking about this kind of fracture, not the little cast fracture now. However, the fractures in our head seem much more catastrophic. They really caught our attention when the teeth fractures in half, and we remember that, and we kind of count in our head, but we didn't count the 4 times that on hygiene we told a patient that poor patient that they have secondary decay under a restoration, and that we need to do something about it. That doesn't seem, it seems normal. Well, probably the diet, probably the flossing, it's probably all these things that lead to caries under an oral restoration. To me, this idea that teeth fracture has a problem of survivorship bias. We see the fractures and we want to fix the fracture. We want to fix the problem of teeth fracture, especially the ones that have posts in it. However, when we have a tooth that has a post and a crown and we see decay, we think that decay has nothing to do with the post, nothing to do with the crown, nothing to do with the restoration. It shows, teeth get decay. The other thing that has to do with post is the fact that it's easy to do research on post rather than to do research on fracture. We have it on the screen now. You put a tooth on a piece of epoxy, you push sideways and you see how it breaks. And you push it into the brakes and you see how it breaks. To me, it never made sense to cut a tooth more to make it stronger. It never made sense. We're not making anything more than what God made, if you want to talk religion.
Right.
We're not reinforcing anything. What
That's
we're doing
proved in the literature too. Actually, that's been proved. Yeah.
We're not reinforcing anything. So we've been fixated. We fix it. We're trying to prevent fractures that don't really happen. What happens is secondary decay. And secondary decay happens because the more you drill, the deeper you are, you're denting, and the deeper you are in cementum. Once you're in cementum, not even with the gauze of adhesion, you have any help. And this thing, anything that you're going to push sideways is going to put stresses on the adhesive layer or on the cement layer pass, and you're going to get leakage and secondary decay. So I always understood the definition of a post. The definition of a post was to, as Anvita said, to hold the core. So the moment that I understood that retention and resistance are no longer needed is the moment that I understood that I didn't need a core ever again. And the moment I understood that I didn't need a core is the moment I understood that I didn't need a post. And the moment I understood I didn't need a post, I started thinking about fracture, no fracture, what kind of post, how do I put it in, how do I prepare if I get a ferrule or not. Ferrule, if you don't have it, you don't have it. Deal with it. Because if you don't have a ferrule, usually you still have a tiny bit of enamel rimming around. And this idea that we're trying to prevent fracture by removing that little bit of enamel and making a 2-3 millimeter ferrule, and now you're indenting or cementum. Because you're trying to protect it from fracture, but then you're going to ignore that 5 years from now, 3 years from now, you get secondary decay. To me, it made no sense at all.
Right.
So I stopped using ferrules and I stopped using posts and I stopped using all of that when I understood that all I need to do is to reconstruct what I have. And if I have a hole because it's endodontically treated, I'm going to use the hole. I'm going to go in the hole as deep as I can, and I'm going to save as much enamel as I can. And that's the end of the story. To me, it's not as complex as we want to make it. We just look at the mechanic of tooth fracture. To me, the number one problem in dentistry, or the number two problem in dentistry, as I said in previous episode, number one is access to care. Number two is secondary decay. And I see a strong correlation of people try to drill more enamel out of a tooth to protect it from supposed fractures that in reality don't happen as often as a secondary decay. And we do know that any enamel that you have, you want to keep it. So that's how my mind, pretty early out of residency, come out of this entire discussion of the fracture, the no fracture, the ferrule, the no ferrule. I don't need a post because I don't need a core. I don't need a core because I don't need retention or resistance. And I don't need retention or resistance because I have adhesion. End the story for me. That's how I always thought about it. But I see the survivorship bias on, we see the fracture, we freak out, we want to fix the fracture.
I'm gonna add a caveat to that whole thing. So in this whole discussion, my personal feeling where the huge issue exists, and I'm gonna take the devil's advocate on this, are two things. Number one, we need to reinvent the endodontists. And right now, I'm working with a couple of endodontists here at Loma Linda where their access openings are so small that I can't even think of getting composite down in there, leave alone a post. So
amount of remaining tooth structure. Like Dr. Ortiz said, it's the amount of remaining tooth structure. Save healthy
correct. And
tooth
so
structure.
when we look at this, and general dentists are out there doing endos, people ask me why I don't do my endos. I go, because if an endodontist could do a 5-canal molar, and I have a hard time filling the access hole, if I can't do that, I don't belong doing an endo. Because of destruction of tooth structure. Number two,
Right.
the other number two one is this. Sadly, there's a lot of insurance driven, and an insurance company will quickly pay $365 for you to drop a post in a hole. Bingo. That's
Right.
just like that. But they won't pay you to go to the pains and the effort of preserving that little rim of enamel and preserving how you fill that hole. So I think we're driven two things, is the insurance industry to a doctor who's looking at a tooth and he goes, or she says, well, I got a crown, I got a post and a core, that adds another $400 onto my $1,400 crown. And I can throw an endo in there myself and I'll do the endo. And now we've just destroyed the tooth. So I'm a little bit jaded in that world.
My follow-up to that, which is again how we read. My follow-up to what you should say is this: is the insurance pushing the doctor to do this, or is the doctor doing something that they shouldn't be doing?
The doctor is using the ability to use the insurance code to pay the money. That's simply that.
So the doctor is being unethical.
I think both points can be true. Doctor is
in some cases, doctors
they're certainly not being current, but also they're driven by hey, this is what the insurance company will pay for. Okay,
right, but let's go further back than that. Even my alma mater, Loma Linda, they still have a lecture in that D3 year on post and cores, and I go AWOL when I'm over there, and I go, why are you even teaching this?
I can guarantee you most dental schools do. I can guarantee you that I'm in a lot of dental schools.
They teach it here as well, and that's why when I'm on the clinic floor, a lot of the general faculties want to do a post, and then when the students approach faculties who are prosthodontists, we are like, no, I could have shown some radiographs that happen day to day, and you would be surprised at how much tooth structure the students end up destroying, because the whole idea is right here, because they get taught in the dental school, and some of the general practitioners are still practicing it, and then somehow we're not taking care of the tooth structure, and it's so redundant. We're destroying the tooth structure to place it.
So I don't think that the dentist is being unethical necessarily in their minds. They're only doing what they've been taught by their own minds.
Exactly. And we are still teaching it. So until we change the paradigm of teaching, I don't think it's solvable.
Well,
should we accept?
Let me bring this home for our audience out here, because remember, our audience is watching, trying to make a decisions here. So we've got 3 prosthodontists and one of the top adhesive dentists, general dentist, but does essentially mostly adhesive, all here that you're all watching today. And with Dr. Young, about 30-40 years experience of not doing posts and doing thousands of restorations, is not seeing failure. Dr. Ortiz mentioned, for 12 years he hasn't done post, and same thing, not seeing failure. And then you can see what Dr. Maharishi said from this literature review, that it's somewhat equivocal, meaning no necessarily, maybe the meta-analysis doesn't show too much difference between the two, but all of us that have practiced see when we remove too much tooth structure, it clearly is a detriment to the tooth. So then, we need to bring it home to a point that if you believe and that you have reasonable enamel to bond to, reasonable tooth structure, save as much as possible. And what I'd like to do right now, let me maybe I think will help the audience. Let me share.
Are you seeing my screen right now? So this is what I try to teach my students.
Yeah.
This is the way, like from the Star Wars analogy.
From our Star Wars movie, yeah. So
yes.
let me please share the screen.
Are we the resistance?
We
We are the resistance, exactly.
We're the heretics. We were heretics back in the late 80s.
let me share the screen for a second. I like the term defect-driven preparation. That's a different way of saying the same thing, only take away the bad stuff, okay? So, I think all of us today, when we look at this, most dentists on earth would crown this tooth, all right? For me, and I've thought this way for a long time, you guys, and I still learn from both of you. So I appreciate everything that you all do, and that's why I have you guys on here. Today, if it was my tooth, I think it's maybe folly to try and save this little teeny tiny thing right here, that mesiolingual cusp, but these buccal cusp are in great shape. We just had a little decalcification there, and they threw a little composite in here. And learning from my good friend, Dr. Ortiz, who's online, we machined something out, and then we finish it, and we end up with a very nice restoration. Those two cusps are going to do fine as long as we don't do some sort of a balancing problem on top of them. I didn't want to show that right there. Let me back out. Okay, so I'm talking more along the lines of, and we'll get into this later about talking about saving a cusp, but I want to show what I'm talking about right here. That'll be maybe a future topic right there. So this is a very typical thing that we see, right? That somebody's had a root canal, and the reason for treatment, basically, the late girl was going to get married, and she had a large, gigantic smile that you could see her tonsils, basically, and the photographer told her to get some treatment. So this is kind of a perfect case where the root canal is fine. I should have thrown in the radiograph. Everything looks fine, but we got very small, spindly roots. So my belief is to take out, we're going to take out the bad stuff. We're going to take out the amalgam and caries. I don't like to leave caries in teeth. I know there's some literature that says that maybe it's going to be possible. Then from there, the simple thing to do is just look around for what's undermined, what's fractured, what you see is problematic, and there has to be some clinical judgment here, because we don't have a study to show what happens if we restore this, okay? But we know over time, if we see fractures going down buccal or lingual, we're probably going to lose a little piece of this tooth structure. But to draw attention to this, and I agree with Dr. Ortiz here, we have a very good distal marginal ridge here that's got dentin support. And for me, honestly, what I look for to save a cusp, and this will be a whole topic, we'll talk about it later, is do I have dentin support? Yeah, decent dentin support. It doesn't matter to me how thick it is. It can't be too thin, obviously, paper thin, but if we have some dentin support here, maybe a 1/2 or 1 millimeter dentin support, and I don't see the cusp all fractured up, I'm going to go ahead and save it. So my next thought process is I just take away the bad tooth structure. I prep down until I get to reasonable tooth structure, so I have a minimum thickness of my ceramic, 1.5 millimeters, okay? And then I stop, and then I look around and see what else is still happening. All right, we removed some of the stuff out of the canal and exposed the root canals, the gutta percha right there. Now, I apologize for not putting in the radiograph, but the roots were very spindly, they're very curved, they're not real straight roots. So I was very worried about putting in a post in this. When I can engage this space, and I'm not even sure we need to do that, to tell you the truth. So the only rest of it is to look around. We had some interproximal caries here, so I'm going to drop this margin down below the contact as long as we keep it in enamel. I have to agree with Dr. Ortiz. My preference is I'm going to try and save a marginal ridge if I can. There'd be two reasons that I might not save a marginal ridge, and we can certainly debate this. If there's a lot of interproximal caries on the adjacent teeth and you're worried about, you might want to extend a little bit for that, even though we didn't like that word. We extend to save, I guess not for prevention. And also, too, if I could keep the margin in enamel, if I could drop this down, but I chose to save it. So I can tell you experience over the years, and again, experience is anecdotal, but it still has some value. And I agree wholeheartedly with what Dr. Ortiz said. As long as we've got a periphery of enamel, save it. This periphery of enamel alone will cause virtually 100% success to the restoration. And so that I think is what the literature is basically showing, and I think what you all have been saying is that let's save that rim of enamel. Okay, let's make sure we have at least a minimum thickness of our restoration. Let's take out the diseased tooth structure, or at least most of it, and any fractures. And the only thing I would like to say about a fracture, I agree with you guys too. I think where the big mistake that people make where were we on this, looking at a fracture here. So this is a large old amalgam that I removed, and you can see some caries here. Most people would jump in and just take all of that out. I agree with you. I know Dr. Ortiz talked about this last time. The only thing that I'm gonna be thinking about, I'm gonna take out obvious disease. And when I see the obvious disease stop, let's say movement and or leakage of tooth structure in either direction, I have no problem leaving these cracks in a tooth, because I believe the restoration, we can seal that, and then we can end up with something like this. And I have to tell you, as Anvita knows, and I mentioned to you all before, that we did over 3,000 restorations at UCLA, and we were tracking them real well. And over time, I believe we had one fail of bonded EMAX restorations. Now, you never know people that didn't show back up, right? But the restorations we followed, and I think we followed close to 2,000 of them since 2005, with graduate students and me, bonded onlays on posterior teeth, and we saw one clinical failure. Our goal at some point was to do a retrospective analysis. That's a little trick you do in a university. If you do it retrospectively, you don't have to go through IRB. But unfortunately, a bad fire happened and closed our program down in 2017. So anyway, let's stop. Let's come back to everybody in the crowd, and maybe we'll finish up with some perspective on that. Do you guys agree, disagree? Do you what alterations would you do based on what I said? And I guess one thing would be nice to finish up, and let me just tell you one thing is there still maybe one small indication for a post? And yes. Let me just suggest for me when it would be, yeah, and I want your perspective. Okay, if I'm going to do a bridge, okay, and I got one abutment that's compromised, but I think it will survive and support a bridge. I'm probably going to do a little bit of a post and a core, maybe only go down the canal 2 or 3 millimeters like Dan Nathanson used to teach, do a composite buildup. So we just get some lateral stability, but still take advantage of adhesion. That would be my only reason for doing a post and a core today. And the post would be very small. And the goal would be to just maybe engage 2 millimeters of the canal and do some bonding. So I'll shut up and let the other experts in the panel share their perspectives on this. Dr. Ortiz, Dr. Ortiz, you go.
Indications for a post. The tooth is to be extracted pretty soon, and I need to temporize it. I can put a post on.
Okay.
The other one is the patient is over 95 years old, and I need to make that tooth go to the grave. A little bit of decay in 3 years is not a big deal. Let's put a post on it. So as it debonds and it's micro moving, I don't care. I just want that thing locked in there. You know when it's locked in there?
Right.
Those are the true indications for a post that I have.
Okay. All right. So not too dissimilar. I might extend that a little bit if I thought the tooth might be salvageable and just to get a little lateral resistance. Okay. Dr. Young, you want to share your thought process? You said you haven't done one. Maybe you never. Maybe you don't do bridges.
No, I have bridges. I have a couple cases that I can bring up. I'm not going to, but I just basically believe if they're 96, 7 years old and it's broken off at the gum line, if I can get a 3 millimeter ferrule, I'm using Carrari's newest universal flow that's got like an 86% fill. I'm just going to blow it. I have images in my lectures now showing it. And there's no logic in why these should last as long as they have, but they have. And I think the secret to it all is you either put it in compression or you put it in tension. And really what we're trying to do is keep a tooth in compression, because the minute we get into tension, we start getting into the fracturing issue.
Right.
So that's kind of what you're doing when you're doing all this.
That's similar what Dr. Ortiz. But that actually echoes what Dr. Ortiz said. Basically, he said that as long as he could get some ferrule, some grab, some adhesion, that he's going to opt for saving the tooth. It's just a pure...
3 millimeters isn't as big as you think it is. I mean, it's,
right.
If it's enamel, I'm not going to take the enamel. I'll keep the enamel because I can bond to that. I'll maybe ferrule if I'm down to that.
I think we got Dr. Anvita, who your quick thought process, and then I think let's answer a couple of quick questions, and then we'll wrap. Okay, guys?
Yeah, so just to wrap it up, I think you all brought a lot of great points, and I think this is a nice segue to move into the next topic for our podcast, which should be defect-driven presentations or onlay preps. And we can also kind of build-ups, yes. And also we can also rant about how there is no standardization of onlay preps. And that's a common question I do get asked in dental school environment, because not every prep is the same, but that's the nature of these restorations.
Good, right? Isn't that a good thing?
Well, that's the art form of understanding.
Yes. So it's
we don't want a standard prep, right?
Yes.
We don't want standard.
You cannot have a standard prep. Yes.
You're free flow. You have to understand the concepts, the principles, and then you create.
And actually, Dr. Ortiz was co-author on a paper that was very extensive on preparation design. So let's review that next time.
Yes.
We'll get into that.